Thank you, Dr. Chandru. At the outset, I would like to thank Dr. Mohan, Dr. Anjana, and Ranjit for giving me this excellent opportunity to be with all of you to discuss about the dyslipidemia guidelines. What is new? You are permitted to take photographs of my presentation, no problem. What I will do in the next few minutes, probably I would like to concentrate on the RSSDI guidelines or the consensus statement which got published in the International Journal of Diabetes in Developing Countries in 2022, and the Lipid Association of India guidelines. We have been actually trying to come out with a lot of consensus statement in the last few years, starting from 2016 up to 2024. But 2022 guidelines focused mainly on management of diabetic dyslipidemia, which I thought I should concentrate. The American Diabetes Association, which released its guidelines now, probably also had concentrated on dyslipidemia, which I will touch, which will be useful for all of us. The ICMR INDIAP study had focused not only attention on the prevalence of diabetes, but also on the prevalence of dyslipidemia, which was projected as 81.2%. If you look at the problem of dyslipidemia in our country, it is always the higher triglycerides and the lower HDL, which are also seen even in this particular study. It is about hypertriglyceridemia 32%, the low HDL is about 66.9%, and the low HDL is about 66.9%, hypercholesterolemia 24%, high LDL is about 20%. If you look at this, the LDL levels are almost normal in many of the individuals who are living with diabetes in our country. If you look at this projection, it will tell you that type 1 diabetic patients, the lipid profiles are similar to controls in glycemic control is good. Type 2 diabetes, the typical atherogenic dyslipidemia where you have an increased triglycerides, the lower HDL. But in addition, you should also remember that it contains a lot of problems. In addition, the two important things that need to be kept in mind. Number one is that the higher levels of small dense LDL cholesterol. And then the fourth one is the increased levels of ApoB. So there are four components in atherogenic dyslipidemia, not three. High TGL, low HDL, increased ApoB, increased proportion of small dense LDL cholesterol. If the poor control of diabetes is seen in people with type 2 diabetes, you have almost the same similarities in all parameters except that there is an increase in the LDL cholesterol levels. In all hypertriglyceridemic states, you must remember there is always an increase in the non-HDL cholesterol, increase in the small LDL particles, higher levels of LDL particle concentration. What is this non-HDL cholesterol? It is the greater predictor of the cardiovascular risk than LDL cholesterol as per the recent evidence that is available with us today. Understanding about the non-HDL cholesterol, you take all lipoproteins, you remove the HDL cholesterol, which is anti-atherogenic, whatever is remaining comes under one label, and that is the non-HDL cholesterol, which includes LDL, VLDL, IDL, VLDL remnants, chylomicron remnants, including lipoprotein little a. Please remember that. Everything comes under one label, that is non-HDL cholesterol. Simply you require only a calculation, total cholesterol minus HDL cholesterol, you get the figure, and that is non-HDL cholesterol, which has assumed a lot of significance in the recent past, even by epidemiological studies, observational studies. All of us get confused, which is important, LDL is important, or non-HDL is important, or ApoB is important. I would like to tell you the basic information, which I am sure that many of you know about it. LDL measures the cholesterol content of LDL as well as lipoprotein little a, number one. Non-HDL measures the cholesterol content of all atherogenic lipoprotein particles. The third, ApoB concentration measures the number of all atherogenic particles. If you ask me what is the best test which can probably indicate the atherosclerotic cardiovascular burden, it will be ApoB. Non-HDL cholesterol is the poor man's ApoB, because simply you just calculate and then identify who is at a very high risk. I think that's the message that I thought I should share it with you. Let me now try to tell you about the recommendation by RSSDI as well as the Lipid Association of India. There is no difference of opinion between these two organizations as far as the fasting or the non-fasting lipid profile is concerned. All of us should get into the habit of only non-fasting. Fasting is no longer recommended for you or your patients. to be sent for the laboratory, and the laboratory people refuse. No, don't come here. Tomorrow morning you come here at 7 o'clock, we'll take the blood out. I think that's a bad information that people are now trying to spread. I think one has to come out of that. Always try to insist that it should be a non-fasting lipid profile, because it is very, very easy for any patient, number one, for cardiovascular risk assessment, number two, patients who are admitted in ICU with an ACS, it becomes simple for you to draw the blood and send it for analysis. In children, very useful, if preferred by the patient, because he has a lot of appointments, so the next schedule is there for him. Yeah, in diabetic patients, if they are willing to do that, in elderly people and patients with a stable drug. But can you still hold the place for a fasting lipid profile? Yes. If the triglyceride levels are more than 400 milligrams as recommended by Lipid Association of India, or 440 if it is exceeding 440 milligrams as recommended by RSSD, which had actually endorsed the recommendation by the European Heart Journal in 2016. If those patients who are actually having a good follow-up in our clinic for hypertriglyceridemia management, or those patients who are recovering from pancreatitis, in those group of people you require a fasting lipid profile, and that too for triglyceride. LDL cholesterol plays a central role, a pivotal role, an important role in not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis, leading into clinical cardiovascular events such as acute coronary syndrome or sudden death. We still believe that the LDL cholesterol still plays the same role what you get in people without diabetes. The same role is actually played by the LDL cholesterol even in people with diabetes. You have huge body of evidence with regard to the role played by LDL cholesterol. You have Mendelian randomization studies, observational studies, biological information, molecular studies, and randomized control trials. The randomized control trials are very important. The people who have used the statin, HMG, coenzyme reductase inhibitors, the more the reduction that was witnessed, not only in the primary prevention trials, but also in the secondary prevention trials, the more benefit that you are seeing in the cardiovascular risk, not only in morbidity, ladies and gentlemen, including mortality. So you get mortality benefit as well as morbidity benefit as far as the statins are concerned in the usage for lipid lowering, particularly for LDL lowering. There are three meta-analyses which are projected here. The first one, actually 26 studies which were taken into consideration for this meta-analysis, which included 170,000 patients. Number two is the 49 trials which included the second meta-analysis. The other one is the 52 trials. One had used only statin, the other used different therapies. The third meta-analysis, which included all the trials, they have seen people with ezetimibe, with a statin, with a PCSK9 inhibitor. All of them had come to conclusion that if you are able to reduce 1 millimole of LDL cholesterol, that is about 38.7 milligrams of LDL, you can expect a reduction of cardiovascular events to the extent of nearly 20%, 21%, 22%. Please remember that that is a message what I thought I should share it with you, because you need to be very, very aggressive as far as the lipid lowering is concerned, particularly the LDL lowering. How to assess the cardiovascular risk in your patient? I think many of you, including me, were not doing it in the past. But time has come now for us to assess how to do for our patients to find out who are at risk of developing a cardiovascular risk in the next few years. The risk that was projected by the ACC-AHA in 2013 is a calculator, ACC-AHA calculator, which cannot be used for Indian population. The European Society of Cardiology had come out with this recommendation using SCORE, that is a systematic coronary artery evaluation, SCORE 1, SCORE 2, SCORE 3, SCORE for elderly, all those data are available, but you need to multiply it with one factor, only then it is possible to get it implemented in the Indian population. But these people have recognized that people with diabetes are considered either moderate risk or high risk depending on the duration of diabetes or the target organ damage. And what is the recommendation as far as the high risk is concerned? You should bring down the LDL cholesterol to 50% levels less compared to the baseline value, number one. Number two, it should reach the levels of 55 milligrams. That's the recommendation given by the European Society of Cardiology. In addition, they also introduced the term called few very high risk individuals, very extreme risk group people. Who are the people? People who are getting recurrent attacks of, for example, stroke, coronary artery disease, or a peripheral vascular disease, or a polyvascular disease. In those people, you need to probably bring it down to the levels of less than 40. Before this, it was published in 2019. In 2016 itself, the Lipid Association of India came out with a consensus statement saying that very high risk individuals should keep the levels of LDL level less than 50 milligram. So that's the one important information what I thought I should share, that the Indians had witnessed the publication from Lipid Association of India that we should keep the levels less than 50 milligram in those people who are at a very high risk when compared to those projections which are made 3 years later by the European Society of Cardiology. RSSDA started recommending Q3 risk score, which that's the best one. But I will not go into the details why they recommended, what is the difference between this and the Lipid Association of India recommendation. This is a recommendation given by the RSSDI. You have to use the Q risk curve, identify whether they are at a moderate risk or a high risk. Depending on that, you should use these drugs starting from a high dose statin, moderate dose statin, high dose statin, go for ezetimibe, go for PCSK9 inhibitor, depending on the risk what the patient is facing. That's the message what I thought I should share. Regarding people with type 1 diabetes and children, what should be the level of LDL cholesterol? Less than 110 milligram. If it is more than 130, you need to interfere and put the patient on a lipid lowering drug. This is about 2020 when we came out with the guidelines, not specifically for diabetic people, but the general guidelines that was endorsed by the RSSDA also. And they have designated this high risk, very high risk, extreme risk, 3 groups. High risk people, diabetes with no risk factor at all, or only one risk factor, there is no target organ damage, keep the levels less than 70. If you have a laboratory under your care, see that you give this value of less than 70 milligram for all patients with the diabetes. Number one. Very high risk individuals, people with diabetes with more than 2 risk factors, there is no target organ damage or evidence of target organ damage, you consider them as high risk, very high risk people that you should keep the levels less than 50 milligram. Extremely high risk in those group of people in whom you have polyvascular disease, target organ damage, more than 3 risk factors are operating, you should keep the levels less than 30 milligram. That is, in 2020 we started coming out with this and they have actually accepted it. This is a recommendation from Lipid Association of India, divided into 2 groups. One group, no cardiovascular disease, patients with the diabetes, there is no target organ damage, 1 risk factor or no risk factor, only with the diabetes, keep the levels less than 70 milligrams. Target organ damage, and the second one, more than 2 risk factors are operating, you need to keep the levels less than 50 milligrams. If you have atherosclerotic cardiovascular disease established, the same rule applies here also. Divide into 2 groups, A, B. A, please, that's one persons who have developed atherosclerotic cardiovascular disease with diabetes, they are at a high risk of developing further events also. You need to keep the levels less than 50, but optional is 30. People in whom you have polyvascular disease, ischemic stroke, ischemic heart disease, and then the peripheral vascular disease with the diabetes, in those patients probably you need to keep the levels less than 30 milligram. That's the recommendation given by the Lipid Association of India. And I don't want to dwell here. If you can just browse the net, www.lipid.net, you can identify how we had probably framed this sort of approach in the form of an algorithm which can be useful for you to identify who are at a risk in developing a cardiovascular disease in the next few years. Justification for Lipid Association of India recommendation, people criticized it. When we came out with the recommendation 50, 30, then they started criticizing it. It is important to initiate treatment for dyslipidemia in diabetic patients as and when you make a first diagnosis of diabetes. Please remember, you should not stop only with the OAD or with the insulin or with the combination of drugs to tackle the hyperglycemia. We need to be aggressive. We need to be committed, not only to control hyperglycemia, but to control all other coexisting risk factors in people with diabetes. Please remember that. The one important coexisting risk factor is the lipid, which you are supposed to tell them the goal, what you want in that particular individual. So these are all the things why we wanted to come out with this recommendation. Unique features of diabetes. Anjana has already projected that the obesity is increasing, metabolic syndrome is high, prevalence of diabetes is higher, younger people are getting diabetes. You have Asian Indian characteristic with hyperinsulinemia, with insulin resistance, with the low levels of adiponectin, higher levels of high sensitive CRP. All those things are there in our population. We need to be very, very aggressive and not to control, not to keep the levels what has been recommended by the other organization. Suffice to say that we need to probably follow the Indian guidelines for people in India. So I don't want to dwell here because of the time lag. Regarding statins, I think RSSDA came out with the recommendation that statins, low dose statin should not be prescribed for any patient. Both the RSSDA and the Lipid Association of India had given a consensus statement. So, in fact, the RSSDA came out with the recommendation for pitavastatin, which I will not go into the details, saying that it is a good drug, 1 to 4 milligram, give it, and then it is one that can prevent the new onset diabetes. It is the one that will not go in for complications, including myalgia. So many advantages are there, but you don't have cardiovascular outcome data to emphasize the information about the pitavastatin to be used widely. Ladies and gentlemen, that's a message that has to be kept in mind. Just because pitavastatin has been projected, you should not get into the impression that we can all treat patients of diabetes only with the pitavastatin. No. The drug that I am going to tell you now is a non-statin drug. Improved study has shown efficacy of ezetimibe, non-statin drug, which was used in conjunction with the statin, which has shown the effect of reducing the LDL cholesterol to 53 milligrams. And that got reflected in the, I'm not going to, it's not working? It's not working. Yeah, it's working. The improved study has shown adding an ezetimibe with the statin can improve not only the LDL cholesterol lowering, but at the same time it gets reflected in the form of reduction of cardiovascular events, particularly in people with diabetes to the extent of 14%. That's most important because ezetimibe is a drug that should be chosen by all of us in association with your statin prescription. If you can give it even at the start of the treatment, that is ideal. 4-year trial had evaluated the efficacy of evolocumab. See, at the end of 4 weeks, you can see from 90 it touched 30 milligrams. Continued throughout the period of study, saying that the 4-year trial had given the information about evolocumab and its usefulness in controlling not only the LDL but also the primary endpoint came down by 15%. People who had levels less than 10 milligrams in 4-year trial, at the end of 4 weeks, they dropped to 10 milligrams. They were all followed up till the end of the study. People were surprised to see that they had more benefit, nearly 30% benefit when compared to the original people who had only about 15% reduction. ODC outcome trial, aliricumab was used in this trial, which had again shown 15% reduction in the primary endpoint. ODC had another study called ODC diabetes dyslipidemia trial, which has shown a reduction of non-HDL cholesterol to the extent of 32.5%. Usage of evolocumab or aliricumab concentrates not only on LDL, VLDL, chylomicron, remnants, and then the remnant particles, LDL particle numbers, non-HDL, everything comes down. Please remember that. Do you have side effects of all these drugs when you are using it in combination? Statin, ezetimibe, plus PCSK9 inhibitor, statin, ezetimibe, no PCSK9, but inclisiran. Or if you are giving all these drugs, are these patients going to get a problem of side effects? Nothing. You can just see there is no cognitive disturbance, there is no increase in the stroke, there is no new onset diabetes. All those things have been highlighted in this particular projection. This is about the inclisiran, which has come to the market in Indian country. You have only scanty data with respect to the cardiovascular outcome. It can be used as an injectable, but is better when compared to the compliance as far as the drug is concerned, better when compared to evolocumab or aliricumab. Bempedoic acid should find a place whenever there is a statin intolerant. True statin intolerant, bempedoic acid 180 milligram per day in association with statin or without statin with ezetimibe, you can always give this for your patients who are statin intolerant. You have residual risk. In spite of all this, you have a residual risk. Residual cholesterol risk, residual triglyceride risk, residual LPA risk, residual inflammatory risk, residual thrombotic risk, residual diabetes risk. For residual diabetes risk, they are here to talk about the GLP-1 receptor agonist and all those things. But we need to concentrate on the triglyceride. There is one study called Reduce-IT trial which had used the icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given to patients, had shown a reduction of primary endpoints by about 25% and secondary endpoint by 26%. So the lifestyle intervention has to be implemented right from the beginning. Primary prevention recommended by ADA. If the patient is not having any atherosclerotic cardiovascular risk, additional risk factors are present in between ages of 20 and 39 years, you can use statin. 40 to 70 years, depending on the presence of atherosclerotic cardiovascular risk, you can use moderate dose statin. In those people in whom you are not able to achieve the goal of 70 milligram, use the other drugs like ezetimibe or PCSK9 inhibitor. In people above the 75 years of age, already used statin, continue to use it. You are going to initiate statin, talk to that old man, talk to the relatives, and then give prescription. The lifestyle modification, in addition to lifestyle modification, you should always try to use the combination drugs. Not a single drug, combination drugs. That's the recent trend. You should move away from high dose statin to high dose lipid lowering therapy. High dose lipid lowering therapy. That should be the motive behind. I think I need not, because time is up, I don't want to talk too much about all this lipid lowering. Suffice to say, if you have a triglyceride problem, in those patients with diabetes, with the ASCVD, the LDL cholesterol reaches 70 milligrams and less than that, the fellow has got additional risk factors. Try to use icosapent ethyl ester. 2 grams in the morning, 2 grams in the evening, to be given in conjunction with the statin, probably will help this patient to bring down the cardiovascular risk. Statin plus fibrate, generally not recommended. Statin plus niacin, generally not recommended. So ladies and gentlemen, my final message is that earlier the better, lower the better, longer the better. Otherwise your life will not be long. Thank you very much, ladies and gentlemen.